Become a better doctor. Streamline the learning process with over 60 hours of organized, high-yield content. Subscribe now to get access to our premium content.
In this lesson, Sleep 2, we're going to cover those commonly tested sleep diseases. They are very distinct from one another, and you're not going to confuse them one for the other, so let's start one at a time. We're going to start with obstructive sleep apnea. The idea here is that there is someone who has excess tissue, that is their fat. It makes it so that their airway collapses, or they're going to have something big kind of in the way of their airway, and that is an obstructed airway. Because they go apneic at night multiple times, they are going to wake up, startle. But they're not going to be fully aroused. They don't realize that they've woken. So what's going to happen, since they're not going through REM sleep because they're waking up frequently, they're going to have daytime somnolence. And people with obstructive sleep apnea usually are obese. And the thing to look for is snoring. Now, you might also see some other things that are going to get in the way, like a large tongue or a short neck. That's usually a product that goes into being overly obese. But you're looking for snoring, falls asleep during the day because they keep waking up. They don't ever get to REM sleep, so they're waking up unrefreshed. Daytime somnolence, obese, and snoring. The way you confirm the diagnosis is with a sleep study called polysomnography on the test. What you're looking for is either 15 apnea spells per hour or a combination of 5 or more apneas plus snoring. The treatment for obstructive sleep apnea is going to be first and foremost CPAP, not BiPAP or bilevel, but CPAP, which is the same as positive end expiratory pressure, which keeps those airways open. If OSA is from obesity, you want them to lose weight. If you contrast that to central sleep apnea, central meaning there's no drive, the respiratory drive is lost, so the patient forgets to breathe, causing a problem of CO2 reaccumulation. The patient is generally going to be caused by opiates, over-oxygenation in a COPD, idiopathic is most common, or the things like a stroke. You're going to confirm this diagnosis with sleep study, polysomnography. But here, because the problem is CO2, because you forget to blow off CO2, because you forget to ventilate, the treatment is going to be with bilevel or BiPAP. Now, if you don't treat OSA, the primary problem is oxygen, which is why you use CPAP and PEEP. If you don't treat it, you might develop cor pulmonale or right-sided isolated heart failure. The other disease of being sleepy too much is narcolepsy. What happens in narcolepsy is that some sort of startle will happen, a bang, a loud noise, or some emotional outburst, and the person will go down and out instantaneously. They have rapid REM. Their sleep latency is reduced, and they undergo a loss of tone. So the patient is going to go immediately out. They go right into REM, so they have a decreased sleep latency. This has to happen 3 times per week for 3 months, 3 and 3. What you're looking for is certain elements. The most important one is waking refreshed. Because they go rapidly into REM, and REM is a restful sleep, people with narcolepsy who just go out, lose tone, go right into REM, wake up feeling refreshed. Waking up feeling refreshed after passing out is narcolepsy. But you're also going to look for things like cataplexy, which is the loss of tone, and they may even wake up paralyzed. Not unique to narcolepsy, but where I'm going to introduce the concept, are those hallucinations around waking up and going to sleep. Hypnagogic, hypno-going, are those hallucinations you experience when going to sleep. Like you're dozing off in the car and you kind of feel like you trip over something and all of a sudden you're startled awake. That's a hypnagogic, going to sleep. The other one is hypnopompic. I remember gogic is going to sleep and pompic is the other one. So somebody who is startled easily, goes right into REM sleep, loses all tone, wakes up refreshed, has narcolepsy. You're going to confirm that with a sleep study, polysomnography. And because these patients often go to sleep, what you want to do is train them to schedule naps. Lifestyle modification first. If that fails, use stimulants, usually amphetamines. This is the person who has trouble with staying awake during the day. Someone who has insomnia has trouble going to sleep. Insomnia is usually a consequence of another disorder, particularly mood. If you have a question on insomnia, it's probably not going to be pharmacotherapy. Insomnia is defined as trouble sleeping. Now, either it's a product of having trouble falling asleep or reawakening. That is, you wake up too soon and have trouble going back to sleep even though you haven't slept a sufficient number of hours. Now remember, you're going to treat the mood disorder first, but this is going to be a question about no mood disorder, just someone having trouble with their sleep cycle. This too is 3 and 3. Has to happen 3 times per week for 3 months. Right, so if someone comes in complaining of insomnia, that is, they're having trouble sleeping, the first thing you want to do is find out how much they are sleeping. Determine their sleep duration. 6 hours is all an adult human needs. So if someone is sleeping more than 6 hours, they're either having normal sleep or they've got jet lag. And some people have trouble with this, right? So if you work the midnight shift, the graveyard shift, 3 nights a week, well, you got to be up for the time you're normally asleep, and then you transition back to a normal sleep cycle. That mix match is going to be hard. The same thing happens when you travel. So what you want to do, if someone is having sufficient amount of sleep, they're just not sleeping when they want to, what you need to do is reorient them. Or use phototherapy. If you travel to an Asian country across the world where they're 12 hours apart, what you want to do is just basically stick it out. Stay awake till the time you're supposed to go to sleep in that area. That's reorientation. Even though you're dog tired, power through it. Or use phototherapy if the circadian rhythm is off, like in Alaska, where days might be really long or really short. Lights on when you're awake, lights off when you're going to sleep. So if you just got some jet lag, but you have normal sleep duration, you need to reorient yourself to a normal sleep schedule. But if you have trouble actually falling asleep, or you get less than 6 hours, you might have insomnia. Now, after the sleep duration, what you want to assess is sleep hygiene. This is where you can really help a lot of people. People will come to you looking for pharmacotherapy. It's usually the wrong answer. If insomnia is part of a mood disorder, you do want to treat it. But primary insomnia usually does not require pharmacotherapy. If you do have good sleep hygiene, though, and you do have primary insomnia that's not a product of another disorder, this is how you can help people. And you can do this on your rotations in the hospital as well. Diphenhydramine, trazodone. And trazodone is an SSRI with a drowsy side effect. So we actually use it for sleep, not for depression. Quetiapine is the same way, an antipsychotic that happens to be sedating. And ultimately, we can use the BZD-1s like zolpidem, knowing that this is the last resort. And zolpidem is going to cause problems with sleepwalking, sleep talking. So if you give your patient zolpidem, let them sleep. But where you can do some real good is the sleep hygiene. And what you want to talk to the patients about are the things to do and the things to avoid. The things to do are to use the bed for sex and sleep. Right? So no reading in bed, watching TV, doing puzzles. You don't want to engage your brain in a real way and associate the bedroom or the bed with intellectual activity. You want to associate it with sex and sleep only. The other thing to do is lights off. That is, when the lights go off, you go to sleep. If you have trouble falling asleep more than 30 minutes, turn the lights back on, get up, go do something. Associate lights on being up and lights off being asleep. The things you want to avoid are the things that are going to keep you awake. So you want to avoid stimulants. Caffeine, amphetamines, cocaine, never stimulants in your sleep. The other thing you want to avoid is exercise and alcohol. Now you might think, hey, alcohol helps me pass out, but you don't get restful sleep, and as soon as the alcohol wears off, you end up being awake. So you want to avoid stimulants, exercise, and alcohol near sleep, and you want to use the bedroom for sex and sleep only and use lights off therapy. So when assessing primary insomnia, what you really want to do is use sleep duration and sleep hygiene, and only after everything else has been ruled out, treat primary insomnia. Obstructive sleep apnea, daytime somnolence, obese snoring, CPAP. Central sleep apnea, forgets to breathe, usually idiopathic, use BiPAP. Narcolepsy, startle, loss of tone, rapid REM, wakes up refreshed, schedule nap, stimulants. That is sleep 2.
Become a better doctor. Subscribe now to get access to our premium content.